to everyone. If you have any questions, please write it down and give it to the volunteers. Is there any questions? If there is no questions, can we have an interactive session, ma'am?
It took us generations to find out the effect of the
Can I ask or make a comment on Dr. Nirmala's presentation on the study that you quoted? You are comparing, being a epidemiology person, I just wanted to ask you, the comparison of the two. One was those who had fundal pressure and delivery. The other was spontaneous delivery. Are they comparable? The one had to have fundal pressure because there was delay or difficulty to get the baby out. The other one easily coming out. So I think that the conclusions are not to be taken the way they have put it.
Yeah, probably, sir. But there are lack of time. I couldn't show other studies also where controlled trials were also done, systematic reviews were done. And they found that especially when a fundal pressure is being given the way it's given, it causes injury and separation of the puborectal part that will give rise to these sort of problems later, pelvic floor disorders. I do agree, sir. You have been an advocate for a fundal pressure.
No, I am an advocate because what is the alternative? A head down there. And if a fundal pressure, it comes out. Without that, you have to have an instrumental delivery.
Yes, sir. Yeah.
So you think of the consequence of the instrumental delivery or a smooth fundal pressure, not the way people do give. The way people give is sitting on top of the fundus with all the weight of the midwife like that. No, a controlled, properly given fundal pressure cannot be condemned because of this paper at least.
That's true, sir. But there are lots of experiences, a quality. They studied the patient satisfaction, so many other things relate to the fundal pressure, because most of the studies are done in Western countries where women themselves prepare for natural labor. But these feedbacks were taken from them. They personally also did not favor a fundal pressure, but some of the studies also done in African countries as well. So this is one of the papers, and I wanted to show them one type of publication. We normally read, now we have a video publication. That is actually a study on video publications. So that's how now people are coming with the video publications. So that's one of the studies I took and clearly demonstrated, because all together it should be when the head is completely in the +5 station. Before that, anything can injure the pelvic floor. That's what they're saying.
Sorry, for want of time, I don't want to take it further, but only thing I want to say is nobody just goes and gives a fundal pressure unless the woman is nearly exhausted, or you have to have an alternative. We have to think of that situation, how to retrieve. Just like when we say a second stage cesarean, people talk about second stage cesarean being so problematic. But the alternative is a difficult instrumental delivery. You have to compare the two and then decide what would have been the step forward. We have to get the baby out somehow.
Yes, sir.
Similarly here, that is all right.
Even a second stage cesarean doesn't protect the perineum, pelvic floor. Yeah, it's already, the stretching has already happened. So even the mechanical force, they found that a pre-labor cesarean is supposed to protect. But there are other factors. It's not only the pelvic muscle strain due to delivery alone. As I said, the first phase of obesity, development problem, genetic, the muscle is not strengthened have the strength enough to bear the pressure of the labor. All these can contribute. So this is not the only factor. But they have selected few practices. I selected a few practices. There are so many practices that they have said, but this is what the WHO's current recommendation, 2023 recommendation.
It is because of the pudendal nerve trauma that is produced in many of these pelvic.
Yeah, it's not. One of my slides showed that it's not just mechanical. This one, stretching alone. There's a nervous injury. There's a mechanical strain. And then the rehabilitation, the postpartum period, so many factors are there. But it's a vast topic to be discussed in a short time. That's what I took a few practices and presented.
Sir, one question. Sir, when you are during the vaginal hysterectomy, Are you usually extraperitoneizing the stumps? That is usually take nowadays people take only one bite from the anterior peritoneum and posterior peritoneum. Previously we used to take a pursing stitch and from the inside aspect of the stumps, and so that all the stumps are made extraperitoneally. Which will you prefer, sir?
I think just bringing the anterior peritoneum to the posterior will probably be a compromise. Ideal would be not to leave any exposed raw area, but that brings with it a problem also, because we take a posturing, then we are bringing the stumps together, that also is not what is expected. So probably the compromise will be anterior to posterior peritoneum that reduces the raw area exposed, because if you leave stumps, especially with suture materials like number 1 or 10 polysorb or Vicryl, long stumps there, that immediately attracts adhesions. We don't see it, but if any time we have to go back with a laparoscope, we will see that all the bowels are going and forming adhesion over there. So I think a compromise will be just a stitch under posterior.
When we were postgraduate students and juniors, madam,
Yeah, it used to be. Yes, we all have changed.
that is it.
Madam, in those days, they were more worried about intraperitoneal bleeding. So that's why we had to exteriorize the stumps.
Exterior stumps.
So we would take the bites so that all the stumps are out. So in case there's a bleed, it's extraperitoneal. That was good old Mayo Ward,
Ward Mayors.
Andy Ward.
Ward mayors.
Ward Mayo. His contention was in those days only for that. Today we don't do that because we're not bothered about that. And as Sir said, even I believe we must close the peritoneum somewhere. You saw me closing the
Just to
peritoneum a
take
little
an
bit.
and close it.
Because
that is.
that matters quite a lot.
Then usually we take the McCall stitch when we are
McCall,
doing
yeah,
vaginal stitch,
yeah.
internal plus
I
external.
was just suggesting a modification of the McCall, because usually we used to say, conventionally it was when we all started, madam also may remember, leave the stumps, initial 2 stumps long, and then finally take a stitch through that and approximate. Classically we are told that if you do a McCall, you should do a cystoscopy to know whether you have kinged the ureter.
Ureters.
That will happen if you go through the middle of that stump.
That is when you go for high uterosacral
Yeah, if
plate.
you take the posterior fibers, the distance to the ureter is more, and they are actually the most stronger of the fibers. If you take them, you get about 2 centimeters cranial, so better pull up and less risk of urinary damage. That is the way we have been recommending of late. This is different from the high uterosacral.
And that is different.
It was much higher. One more point about the peritoneal closure at that time that Kurian pointed out was that our concept that if you have a peritoneal cover, that reduces the chance of ascending infection as well. Those things are having their own downsides as well, so we don't do that. And they say that if you close the peritoneum with a purse-string, cost of pain is also more.
And then in the absence of Dr. Serena, previous cesarean, 2 concerns are: one is the bladder adhesions. Second is the adhesions producing a venereal fixation in the uterus. Some days you come across such cases, uterus is adherent to the anti-abdominal wall.
Just repeat, madam.
Venereal fixation in the uterus. Uterus become adherent to the anti-abdominal wall. Many times you come across such cases. Therefore, when you try to pull it out, find it's difficult. It will not come down. And there is a dimbling of the anti-abdominal wall when you try to pull down the cervix. And also cervix will be pulled up and under the symphysis pubis. All these are the 2 problems that is associated with previous cesarean. In
Yeah,
those cases, what we have to do?
That's always the problem with
Always a
previous
problem.
cesareans, because very often the whole uterus will
Whole
be stuck
uterus will be-
anteriorly.
We can diagnose it preoperatively
Today,
also.
today they even talk of, there are people today who want to do natural orifice surgery or through the vagina
Venots.
using an endoscope. So first they put the laparoscope in, free the anterior
Free the
abdominal wall,
adhesions.
then go from below and take it. I mean, all can be done. As I said, right now we have gone off from doing previous cesareans. The reason being that increasingly we are getting situations where we're just fighting to get it out. But I'm very happy the way Pairi sir and Zarina do. They keep fighting and getting it. You want to say that?
Yeah, Serena already referred to that. uterus stuck to the anterior abdominal wall is a problem. And what she suggested was using the laparoscope, you can release it
Put a
and complete
laparoscope
it.
always.
That is what I would also, Shri Sheth has addressed this. And you know that the Shri Sheth sign,
Sign is-
if there is an addition anteriorly, posterior fornix will be wider and all that. And he also recommends you pull on the cervix and you can see that indentation of the anterior abdominal wall. But all these have their own caveats. You need not have the indentation until you have released the uterosacral. If you have a strong uterosacral ligament, even when you try to pull on the cervix,
It will not
the fundal adhesion will not show up. After you release this, then only the fundal adhesion will show up. So what we do is, we recommend to try pull it. If the cervix is pulled up, that means the adhesion to the anterior abdominal wall is closer to the isthmus. Whereas if it's a fundal adhesion, it will not show up even by these signs. The reason why so much adhesion to the anterior abdominal wall following a cesarean is the other thing you have to remember. Because for a long time, we all gave up closing the parietal peritoneum. We stretch the anterior abdominal wall, there are oozing points posterior to the rectus muscle, which are exposed to the anterior abdominal, to the abdominal contents. So the omentum and the bowel comes and plugs it. So now we have standard recommendation. I hope all of you are following that. We close the parietal peritoneum, not the visceral, parietal peritoneum with monofilament, easily absorbable suture materials like monocryl, along with the cesarean procedure. So hopefully the chance of the uterus stuck to the anterior abdominal wall will become less. But that's a pain. If you have a uterus stuck to the anterior abdominal wall, it's really a problem.
So what's your opinion or recommendation on this pelvic floor repair, especially when you did for that third degree vaginal prolapse? Pelvic floor repair, we have done the sacrospinous fixing. What's your opinion on current, where we stand there?
Usually, the way when we start our training, and I am sure that probably Madam Radhamari also will remember, at that time the classical teaching was, for a prolapse, what do? We do the hysterectomy, whichever way, and then make the vagina as narrow as possible, perineum as tight as possible, bring the uterosacral from both sides and all that. I have other videos here where the vaginal introitus is so tight, but through that the vault can come out. So now our concept is the whole pelvic floor, it needs support, the level 1 support, that is the pericervical ring area. That is where we are thinking about the sacrospinous ligaments, I suppose, or Viren will later talk about the presacral ligament being used laparoscopically, one or the other way. The level 2 is the more important thing that you have to keep in mind, because in the Homo sapiens with the adult posture, what has happened is there is the level 1 strain, of course, natural, but there is more strain on the anterior vaginal wall. So the pubocervical fascia, along with the arcus tendineus, is the one which takes the brunt of the increase in the abdominal pressure when you are standing up. The picture that we usually see is of the woman lying down, so we don't appreciate it. When somebody is standing, I brought the pelvis basically to show that. If you tilt the pelvis, you see that it is the anterior vaginal wall which takes the strain most. And that is why most common prolapse is in the anterior vaginal wall, more than the level 1. This is because the strain of gravity, because of our upright posture, is more on the anterior wall. Of course, tear of the vaginal fascia, everything will also be more with that. So when you talk about the pelvic floor repair, it should be a site-specific repair. As Kurian showed you, during the procedure, bring the fascia back to support it. When we started, it was a posting on the bulging bladder. We did not know or we did not care whether it will king the ureter, whether it will the, if you look at it through a cystoscope, then you will see that the posterior vaginal bladder wall would have been bulging up like that. So that is gone now. The fascia you bring back, level 1 you bring back, didelmiles fascia you bring back, and if the introitus is very wide, you make it narrow. So that is the present concept about the pelvic floor repair we have to follow.
One more question, one more, sir.
Yes,
That,
please give a mic. Okay.
Sir, in your opinion, the these days we are not at all closing the UV fold of peritoneum after cesarean section. Has it increased the number of abdominal adhesions to the uterus?
Personally, I still don't recommend closure of the utrovesical fold of peritoneum because many people don't even bother about the utrovesical fold. They put the incision without separating the utrovesical fold. They take the incision through that. So there is no flap being raised. Personally, I still feel it is worth raising the flap, pushing the bladder down with it so that that flap will come over to cover the raw area on the suture line. The parietal peritoneum is the one that was recommended not to be closed, that we recommend to close. So at the moment, what we recommend is you don't close the utrovesical fold of peritoneum with suture material, but the parietal peritoneum. You have to remember one thing. Why is adhesion formation? Adhesion formation is not the enemy of the doctor. It is the support given by nature to protect the individual. If there is an oozing point, it will be covered by adhesion. If there is a foreign body there, it will be covered by that. So minimal suture material, minimal dead tissue that we leave, less of adhesion. So personally, this is the compromise that we have reached. Utrovesical fold, just bring it back over the suture line on the myometrium, whereas parietal peritoneum, because we are stretched, pulled it open, we bring it back. I know that there are many people who will argue against this. This is the philosophy I keep.
I'm not really very convinced that leaving both the utrovesical and the parietal peritoneum, because for the past maybe 10 years, we've never closed both these peritoneums at cesarean. And we've gone enough number of times. We have not seen too many adhesions. I think the adhesions are caused by basically some hematoma formation, yes. For covering that only Pilicer says to close the parietal peritoneum. But it's your surgical technique, do less harm inside, you get better results. I'm more convinced about that. I don't really think of other factors. Because in some cases it's absolutely still unexplainable. Where you put the laparoscope in, you'll see both sides ovaries sticking onto the anterior abdominal wall. Why did that happen?
Sorry, we are running short of time, sir.